Now, recently, I think you published a paper with your team where you developed 7 questions to find out if a person has a lack of DHA in his diet or not, or a woman has a lack of DHA in her diet. Can you explain us a little bit, or I'm not sure, was it DHA or omega-3 status in general? But could you explain that a little bit?
Yes. So we did a multi-site randomized clinical trial asking, is 1,000 milligrams of DHA superior to 200 milligrams of DHA to reduce birth before 34 weeks?
Okay, that's, yeah.
And what we found, and I mentioned this earlier, is that if women were having a low blood level of DHA, they benefited with it, reduced their rate by half. But if they had a high blood level, there was no benefit of 1,000 over 200. One of the nice things in the 2 trials we did here in Kansas City, there was another trial called Panda that enrolled 300 women, and we harmonized our methods. So we have the same data on all these women. And one of the things we did was we asked the women at the beginning, using these 7 questions, what was their DHA intake? And it's based on a very, Connie Karatko published this a number of years ago. It's asking questions about 3 different categories of fish that have either high DHA, modest DHA, or low DHA. And how much liver do you eat? How many egg yolks do you eat? What else? The other, what is your intake for? Chicken. How much chicken? Because chicken has some. And then also, do you take any supplements with DHA? How much DHA is in it? How often do you take them? We had administered that questionnaire to all 1,400 women, and we have good birth data on 1,310 of those. So why not look at whether intake makes a difference? So the randomized trial, you have to publish what you said you're going to do, and that's based on the blood level. But we started thinking about this practically. If you're an obstetrician, you read our paper, you go, where am I going to get a blood level on this woman? Which blood level should I use? How do I interpret that? Then wouldn't it be a lot easier if you could just use the 7 questions?
Right.
And know the intake. So that's the paper that I'm getting ready to submit today.
Okay.
Which basically showed that if you were consuming less than 150 milligrams, getting the high dose reduced your level of early preterm birth to the same level as women who were getting more.
Right.
Women were getting more at the beginning. If they were getting more than 150 milligrams at the beginning, they also had a low rate of early preterm birth.
Right.
So I mentioned earlier that women who have a low intake in our study did have different maternal characteristics, but the beauty of it is if they got the high dose, it didn't matter that they had these high risk factors for preterm birth because it worked for them.
Okay.
And we've already, it's now standard of care in our clinic to ask women these questions. And when they complete it, a message goes to their caregiver saying, this woman should keep up her good intake of DHA, or she should take more DHA.
Okay. Well, that's a very good idea, because I think that's also one of my last question actually I have for you. I'm not sure in the US, but at least here in Europe, and especially I would say in Germany, do you think are there still so many physicians which still, in spite of all the evidence we have gathered over the years, but still do not really actively recommend the supplementation or the intake of a DHA-rich diet during pregnancy? That's something which I find really very hard to understand. What is your experience?
My experience has been very gratifying. The thing I would say is physicians pay attention to data. And the data is pretty new here around preterm birth. So I think when there's evidence, practice changes. And what's been limiting up till now is when it comes to like improving the intake and the diet, it all sounds very nebulous to physicians because, you know, why? What's the benefit here? Show me the study that the cognition was higher and these kids had higher IQ or whatever is the outcome. The thing that I found really gratifying is that obstetricians understand preterm birth. It's not like IQ where you can wave your hands around and say, well, these people don't really understand what they're doing, or we just don't understand how the brain works. But numbers like this child had a gestation of 33 weeks. Those are recorded right in the medical record. Right, and you can see it, and you say, if you just do this, you can reduce preterm birth. I don't know where this is all going to go, how quickly practice will change, but it's gratifying to me that as soon as I showed this data to our OB, even before the paper's published, they said, we're making this standard of care.
It's wonderful.
It's so easy. It's so easy to ask these questions. And
right.
It's pretty hard to go get the blood measure.